Morning students, today we'll see about pelvic fracture patient management. The pelvic fracture is the most crucial uh, treatment because the pelvic fracture results from high energy trauma. Because of it leads to the high energy trauma, leading to the significant morbidity and mortality, often associated with the multi-system injuries. They demand rapid coordinated care. Then mortality rates can reach up to 20% in the unstable cases, emphasizing the critical need for immediate and effective intervention. Then epidemiology and pelvic fracture classification. Then the pelvic fracture account for approximately 3% of the all fracture and 10% of the major trauma cases. Understanding the classification is crucial for operative management. First one is the Young-Burgers classification. Young-Burgers classification. This classification is the categories fractures by mechanism of injury, mainly for anteroposterior compression, lateral compression, and vertical shear. Anteroposterior compression, lateral compression, and vertical shear. Second one is the tile classification. Tile classification is the focus on pelvic ring stability. Pelvic ring stability. So the type A is the stable, type B is the rotationally unstable, type C is the rotationally and vertically unstable. And third one is the AO classification. That is the most detailed system primarily used for surgical planning due to this comprehensive description of fracture patient. Then initial assessment and resuscitation of the pelvic fractures, mainly by the ATLS protocol. ATLS protocol, Advanced Trauma Life Support. ATLS means Advanced Trauma Life Support protocol for ABCDE. Priority is the A for airway, B for breathing, C for circulation, D for disability, and E for exposure to identify and manage life-threatening injuries. Then hemodynamic instability, common due to pelvis high vascularity, and immediate intervention is critical. Then pelvic binder applications, crucial for immediate stabilization and hemorrhage control, reducing the pelvic volume and external rotation. Then fast exam, there is a rapid ultrasound assessment to rule out the intra-abdominal bleeding and especially around the spleen, liver, and pelvis. Then genitourinary injuries, up to 50% of the pelvis fractures are associated with the injuries to bladder or urethra, requiring the careful evaluations. Then diagnostic imaging. These X-ray features will see about the accurate imaging is essential for characteristics of the pelvic fractures and guiding treatment to each modality offers a unique insight into the injuries. So these features mainly see about the center of the column is the vertebral column. Then first we'll see about the top of the vertebra is the lumbar vertebra. Then lower is the sacrum. End of the vertebra is the coccygeus bone. Then either bone is attached to the hip bone. That is an acetabulum. Acetabulum is articulated with the articulation of the joints. Then the anteroposterior pelvis X-ray. This is the initial view to quickly assess the pelvic ring integrity and identify gross instability. Pelvic ring integrity and identify gross instability. Then inlet and outlet view. Specialist X-ray projection to characterized by displacement and rotation and sacral fractures. Then CT pelvis with contrast. This was made the gold standard for detailed fracture anatomy showing communication and displacement. Then CTA, that is CT angiography, identify the acute arterial bleeding in up to 80% of the cases, guiding embolization. Then ureterogram or cystogram, that is essential for assessing the suspected urinary tract injury and particularly in the males. Then treatment principles are non-operative versus operative. The non-operative management mainly for operative pain were stable, that is the tile A classification. Fractures of minimal displacement focused on the pain management and early mobilization. Then operative management indicated for unstable, tile B and C classification fractures, then significant displacement or open fractures to restore stability. Then treatment goal, restore pelvic ring stability and reduce the pain, then enable early mobilization and prevent long-term complications. Then mobilization timelines, that is early weight bearing encouraged for stable fracture 4 to 6 weeks depending on the pain and healing of the fractures. Then surgical implant for options. Various surgical techniques are employed based on the fracture pattern and stability requirement. First picture is External fixation. Rapid temporary stabilization method often used in the hemodynamically unstable patient can sometimes be definitive. Then second is the OIF, open direction internal fixation. Definitive fixation using plates and screw to anatomically reduce the stabilize the complex fractures. Then percutaneous third picture is the percutaneous screw fixation. That is a minimally invasive approach to the both pubic rami fractures suffering the disruptions. Then post-operative care and rehabilitation. First is the pain management. The utilize the multimodal approach combining the opioids and non-steroidal anti-inflammatory drugs and nerve blocks for effective pain relief. Then DVT prophylaxis. The crucial due to high risk of deep vein thrombosis up to 60% of the cases, pelvic fractures. Then early mobilization. Initiate the as soon as fracture stability, allow following the surgeon protocol and physical therapy guidance. Then physical and occupational therapy, progressive weight bearing, strengthening, balance exercise, and training for activity for daily living. Then inpatient stay, typically 7 to 14 days for unstable fracture, depending on the patient recovery and the complexity of the care needs. Then complication and long-term outcomes. That despite the best effort and the pelvic fracture can lead to significant long-term complications impacting the patient quality of life. Hemorrhage, life-threatening or often arterial, may require urgent angiographic embolizations. No damage, common with sacral fracture, particularly affecting the L5 and S1 nerve roots, leading to weakness of the numbness. Infection, risk of the 10% of open fracture, demanding the aggressive antibiotic treatment and debridement is then must needed. Then chronic pain, the persistent issue in the 20% for 20 to 40% of the patients, often requiring the multidisciplinary pain management. The malunion or non-union occurs when the fracture heals incorrectly or not at all, or then necessitating for revision surgeries. Sexual dysfunction or urogenital causes affect 20 to 30% of the patient long term and significantly impact quality of life.